Okay, welcome. Today we're going to be covering chapter 38, and I think it's a pretty long chapter. So it'll probably be the only chapter that we're going to be covering today. And this chapter is on pediatric patients. Okay, many EMS providers agree that dealing with kids is very stressful. Okay, trauma is the leading cause for fatal injuries in children under the age of 14. Of medical problems, respiratory problems are the most common in kids. And assessment of the pediatric patient varies somewhat different than that of adults. Dealing with caregivers may actually be upset, cry, blame themselves, or be angry at you, or be angry at you. Let's see. Listen carefully and remain non-judgmental. Let caregivers verbalize their emotions and be supportive and display competence and confidence. Now we need to go over a little bit of the developmental characteristics of children when they're, as they're growing into adulthood. So each age group has specific emotional and physical characteristics that affect assessment and treatment. Pain is difficult to assess in most age groups, and ask caregivers what typical characteristics are for the pediatric patients. So let's see if you get to the scene and mother's carrying a little baby, and you notice that he's kind of like tired or weak. Ask her, is he normally like this? And she could tell you, say, no, he's usually very active, or no, he's normally like this. You need to find out if there's anything different about the kid. Okay. Neonates is considered, now this is something that you really have to, understand and memorize. Neonates are basically considered the age group of birth from the day they were born to 1 month. Infants is from 1 month to 1 year. Toddlers is 1 year to 2 years of age. Preschoolers are 3 to 5 years of age. School-age children are from 6 to 12 years of age, and adolescents are from 12 to 18 years of age. Now, the reason you need to understand and memorize these age group is because vital signs on the patient are different depending on the age group itself. Okay, anatomical and physiological differences. Children have less blood and are therefore in greater danger of actually bleeding to death. So they can actually go out very quickly. Children also have lower blood pressure. Children have faster heart rates. And young children extremities are likely to appear mottled. In other words, that color, specific color that looks like a giraffe skin. Also, the child's head is larger in proportion to the body, and temperature control mechanisms is immature and unstable in babies. Children also have smaller airways with more soft tissue and narrowing at the cricoid level, or the cricoid cartilage. Children also have faster respiratory rate, and in children, since they don't carry that much fluid, also can dehydrate a lot faster. Now, age groups and their vital signs. A neonate, remember, a neonate is from the day they were born to 1 month. is 100. The heart rate should be 100 to 205. Anything below 100 is a danger sign. The respiratory rate should be 40 to 60. Systolic blood pressure is 67 to 84, and the diastolic blood pressure should be 35 to 53. So systolic hypotension, whenever you consider a kid hypotensive, should be at less than 60 millimeters of mercury. An infant, remember, an infant is from 1 month to 1 year. The heart rate should be 100 to 180. Respiratory rate should be 30 to 53. The systolic blood pressure should be 72 to 104. The diastolic blood pressure should be 37 to 56. And the systolic hypotension, in which when they're considered hypotensive, would be at anything less than 70. Toddlers, heart rate is 98 to 140. The respiratory rate should be 22 to 37. The systolic blood pressure should be 86 to 106. And the diastolic blood pressure should be 42 to 63. So in this case, what you need to do is you need to do a small calculation. So a systolic hypotension would be considered anything less than 70 plus the age in years times 2. So let's say if the kid is 2 years old. So a systolic hypotension should be 2 times 2 is 4 plus 70. So it would be anything less than 74. Okay. The preschoolers, the heart rate and beats per minute should be 80 to 120. The respiratory rate should be 20 to 28. Systolic blood pressure should be 89 to 112. And the diastolic should be 46 to 72. And again, anything less than 70 plus the age times 2. Same calculation. School-age children, it's up to 12 years of age. The heart rate should be 75 to 118. Respiratory rate should be 18 to 25. The systolic blood pressure should be 97 to 120. Diastolic blood pressure should be 57 to 80. And the systemic hypotension should be anything less than 70 plus the age of the child times 2. The adolescent, the heart rate should be 60 to 100. The respiratory rate should be 12 to 20. The systolic blood pressure should be 110 to 131. The diastolic blood pressure should be 64 to 83. And systolic hypotension is anything less than 90. So adolescents typically have the same type of vital signs that adults have. Anatomical and physiological differences: the airway, the head, chest, lungs, and respiratory rate. Excuse me. Is significant. The also anatomical and physiological changes: the cardiovascular system, the abdomen, extremities. The metabolic rate is a lot faster, and skin and body surface area is also as important. So assessment-based approach to pediatric patients. Okay. Do a scene size up. Look for clues to the nature of the problem. Assess the need for additional resources and determine the scene safety itself. Primary assessment, form a general impression using the pediatric assessment triangle, the PAT. Assess the level of consciousness, assess the airway, assess breathing, assess circulation, and determine priorities. So basically, the PAT assessment triangle, you look for appearance, work of breathing, and circulation, as opposed to PALS, which is a pediatric advanced life support model. You look for consciousness, breathing, excuse me, and color. Primary assessment. Uh, form a general impression using the PAT. Look for appearance, look at the tone, interactivity, or irritability. Consolability, in other words, can you calm them down when they're crying? Look or gaze or speech or cry. The work of breathing, uh, listen to abnormal lung sounds, abnormal posture or position, any retractions, nasal flaring, or head bobbing. Circulation, look for pallor, mottling, cyanosis, and petechiae. Now, petechiae is the little red dots that form whenever you have a compression type of injury. So it's little red dots that appear like in this on the skin itself. Form a general impression using the pediatric assessment triangle. A well versus sick child approach. Conditions presenting with an abnormal PAT findings include the level of consciousness. I'm sorry, that's conditions and look for conditions with abnormal PAT findings, which is remember respiratory rate, effort, or whatsoever. For the PALS, you look for consciousness, breathing, and color. Is the patient going to be pallid, cyanotic, mottled, or whatsoever? So if breathing is adequate, to proceed to the primary assessment. If the patient is unresponsive and breathing is absent or gasping, begin positive pressure ventilations at 12 to 20 respirations per minute and assess the pulse. If there's no pulse, begin chest compressions. If there's a pulse, but signs of poor perfusion are present and the heart rate is less than 60, begin chest compressions. And if the pulse is greater than 60 per minute, proceed to actually to the primary assessment. Primary assessment, assessing the level of consciousness, use the ABPU approach. Remember, when we're checking for ABPU, is if the baby is alert, do they respond to verbal stimuli, do they respond to painful stimuli, or they're unresponsive. Primary assessment, airway assessment, and breathing assessment. So we have to make sure that the airway is open. And once it's open, we need to make sure that they're breathing correctly. And with any type of kid, again, we put, because of the size of the head and the amount of tissue that's in the neck area, we put towels on their shoulders so you can actually cause the head to go into a neutral position, which we also referred to at one point as the sniffing position. Breathing assessment, rapid breathing, normal breathing rates are from 25 to 30 per minute in an infant and 15 to 30 on a child. Check for signs of hypoxia and respiratory distress, and look for causes of rapid breathing. Breathing assessment, noisy breathing, look for noisy breathing, coughing, gasping, or gagging, crackles, wheezing, or stridor, and diminished breath sounds. Remember, with wheezing, you're going to be listening to it in the lung fields, and with stridor, you're going to be listening to it around the neck. Circulatory assessment, assess the pulse. Capillary refill is reliable in children. Assess color, blood pressure, and urine output, and mental status to check for hypoperfusion. Check pulse rate and strength Strength of peripheral versus central, warm or colored, or bands, or on hands and feet, I'm sorry, urinary output and mental status. Strength, check the strength of the brachial pulse. In infants, check for the brachial pulse right under the arm. Oh, well, or on the arm, the arm area. Locate the pulse and identifying a midpoint of a imaginary line extending from the anterior superior iliac spine to the symphysis pubis, then moving your fingertips about 1 or 2 fingers breadths inferior. Yeah, it's basically the femoral pulse. And a child, check for radial pulse. And then you can check, in older children, you can check the carotid pulse. Now, when we're doing what we call the capillary refill, also referred to as the blanching test, press down for a few seconds and let go. And within 2 seconds, it should come back to normal color again. It should turn white and then come back to normal color. Priority determination, consider scene size up by using the pattern PALS and primary assessment information. Priority patients, respiratory distress, anything that's going to cause you to go to the hospital like yesterday is respiratory distress, respiratory failure, respiratory arrest, or poor perfusion. For trauma, perform the assessment first, then the history and baseline vital signs. For a responsive patient with medical problems, a focus assessment may actually be performed. For younger patients, use the toe-to-head approach. Normally in adults, it's a head to toe. In children, you usually use the toe-to-head. When examining the child, if possible, have only the EMT deal with the infant or child. This reduces the fear of the patient may actually experience by being assessed by 2 unknown individuals. Get down on the child's eye level. Towering above the children or child will actually only increase their fear and anxiety. Sit down next to the child whenever possible. If the children under school age, start the assessment with your start with the assessment with your hands and actually save the stethoscope, blood pressure cuff, and scissors until you have developed some type of trust with the kid. Keep the most painful part of examination till the very end, and speak in a calm, quiet voice, and maintain eye contact as much as possible. Even infants will report to calm, will actually respond to a calm voice, and an apparently unresponsive child may actually hear much of what you actually are saying. Never become impatient or lose your temper. This will actually ignite the patient's temper. Switch off with a partner, or take a brief time out for yourself if you need to. Now, the reason they're telling you this is because most adults don't like dealing with sick children, and that stresses them out. Avoid questions that require a yes or no answer. Give the choice of given a choice, a child will actually almost always say no, and ask if you can actually do something to him instead of ask questions in this format. In other words, what they're going to do is if you ask, I'm going to go and check your pulse. Can I check your pulse? They're going to tell you no. So would you like for your mother to actually take off your shirt, or may I do it? Or may I do it for you? Giving the child a choice also empowers him, and actually may be more, shouldn't be, he might seem he's more in control, so it shouldn't be that scary for him. Involve the caregivers or familiar person as much as possible during the care and transport. If your child sees his caregiver respecting and trusting you, he is much more likely to do the same. Okay, be honest. For instance, you might say, it will hurt when I touch you, and wait, I touch you here, but it will only last for a moment. If you feel like crying, it's okay. Children can actually tolerate some pain if they are prepared for it and given adequate support. Ask the children for their help and assure them that they are doing a good job. Have toys, stickers, and rewards to console or encourage the child. Be gentle. Use all appropriate measures to reduce the amount of pain that actually a child must endure. If you must restrain a child, be sure that it is necessary. Use only a minimum degree of restraint for, to be safe, and allow you to provide good care. As a rule, humane soft restraints are much better than mechanical ones. Secondary assessment. Special considerations. There's a pediatric Glasgow Coma Scale, assessing lung sounds and pulse oximetry. Evaluating blood pressures in the pediatric patients. In neonates, the systolic blood pressure less than 60 is considered hypotensive. In infants, less than 70 is considered hypotensive. In children ages 1 to 10, remember you have to get 90 plus 2 times the age in years, which should be considered hypotensive. Medium level, now that would be the upper limit at 70. Remember that 70 plus 2 times the age, anything below 70 is considered hypotensive in that age group. Child older than 10 years of age, the systolic blood pressure is less than 90, is actually considered hypertensive. Secondary assessment. Consider special considerations for assessing the vital signs. You have respirations, pulse, skin, pupils, and blood pressure. Special considerations for taking history. What's the child's interaction with the caregiver? If there are life threats, take time to establish the trust and use calm voice, and include the child's include the child in the conversation. Avoid rapid yes or no questions. Avoid words that increase anxiety. Keep the child with the parent. Examine small children toe to head, and place yourself in the child's eye level. In the secondary assessment, special considerations for taking a history: do not explain things too far in advance, and let the child actually handle the equipment and then touch it to make sure that so they can make sure it doesn't hurt them, or you can prove that it doesn't hurt them. Reassessment, monitor for mental status, airway, breathing, and circulation, and remember that compensatory mechanisms fail rapidly and without warning. And record the vital signs and check for interventions. Airway and respiration problems in pediatric patients. The leading cause of cardiac arrest in pediatric patients is usually respiratory failure. They're too young to actually have developed clots, atherosclerosis or whatever, to give them a heart attack. Failures to establish and maintain the airway and ventilations will actually defeat any other treatment and lead to failure. Compensatory mechanism function until total exhaustion occurs, causing respiratory or cardiac arrest. Early respiratory distress. The adequate depth and rate of respirations, work of breathing is increased, the patient can progress to respiratory failure and respiratory arrest and provide oxygen and transport the patient. Now, basically, this is what you'd be looking for, what you're going to be looking for whenever we're dealing with the respiratory distress. You have increased work of breathing. You have nasal flaring, which basically your nostrils just flare out. Retractions of the neck muscles. Abnormal sounds like stridor or gurgling or wheezing. Abnormal positioning like the tripod position. Signs of early respiratory distress. You have flared nostrils, stridor, neck muscle retractions, grunting, subclavicular retractions, substernal retractions, intercostal retractions, audible wheezing, subcostal retractions, and seesaw respirations. Signs of early respiratory distress provide oxygen and prompt transport to the hospital itself. Remember, kids will react great with oxygen. Well, their vital signs will get a lot better. Okay, decompensated respiratory failure. Patients cannot compensate and are unable to actually maintain adequate breathing. Either the respiratory rate or the tidal volume is inadequate, and the patient requires immediate interventions. In respiratory failure, you're going to have flared nostrils, abnormal sounds like stridor, wheezing, or grunting, abnormal positioning, like sniffing position, tripod position, and whatsoever, or head bobbing. You're going to have in the appearance, they're going to seem irritable or inconsolable. They're going to have a gaze, like they're just staring into nothing, decreased muscle tone. And in circulation, you have cyanosis, pale. Circulation, you can have cyanosis. They might actually show up pale, or they can actually have mottled skin. In addition to signs of respiratory distress, patients in respiratory failure may also actually have respiratory rate greater than 60, cyanosis, decreased muscle tone, and severe use of accessory muscles. Decompensated respiratory failure, respirations greater than 60, cyanosis, poor peripheral perfusion, altered mental status, grunting, or head bobbing. In respiratory arrest, any respirations that are less than 10 is considered respiratory arrest in children. irregular or gasping respirations, limp muscle tone, unresponsiveness, lower than normal or absent heart rate, weak or absent peripheral pulses, and hypotension. In respiratory arrest, you're going to have decreased work of breathing. You're going to have bradypnea or apnea. Remember, bradypnea is slow breathing, and apnea is considered no breathing whatsoever. Irregular or gasping respirations. You're going to have unresponsiveness, limp muscle tone, and you can actually also have cyanosis, mottled skin, weak or absent pulses, and bradycardia. Partial airway obstruction. If the airflow is adequate, allow for patients to actually assume a comfortable position. I'm sorry. Allow the patient to actually assume a comfortable position, administer oxygen, encourage the patient to cough. Do not agitate the patient and transport immediately. You have complete airway obstructions. You're going to have no crying or talking, ineffective or absent cough, altered mental status, cyanosis probable, and this usually requires the use of procedures for relieving the airway obstructions, like the Heimlich maneuver for kids. Establish and maintain patient patent airway with a If no cervical spine injury is suspected, use a head tilt chin lift. If spine injury is suspected, use a modified jaw thrust or the jaw thrust maneuver. That would be the head tilt chin lift, where you basically pull down on the forehead and open up the mouth. That should displace the tongue so you can actually give them oxygen. So another head tilt chin lift on the child. This is what we call that's not the modified, but it's the jaw thrust maneuver. I learned it as a modified jaw thrust maneuver. This is a jaw thrust maneuver itself, which is basically you displace the lower jaw anteriorly and open up the airway. And this is a side view of the jaw thrust maneuver. You lift up on the angle right here, and it causes the airway to open up. You do it anteriorly. Give me a few seconds, guys. So anyway, Eddie, that's you. Wow, the elusive Eddie. We call him Halley's Comet. So anyway, for kids, this is the way you kind of utilize the jaw thrust maneuver in a child. No, hold on, let me just... Emergency medical care. Respiratory emergencies, emergency care for obstructed airway. Remember, you have to suction secretions if there's any vomitus or blood in case. Limit suctioning for about 3 to 5 seconds only, and use appropriate size equipment. So you still have to measure how much you're going to go in there and actually be able to suction, and use a pediatric version of the Yonker and the pediatric version of the suction devices. Now, assist ventilations as needed. If positive pressure ventilations are needed, insert an oropharyngeal airway. And if the patient does not have a gag reflex. Now, remember, you have to measure this also from the tip of the ear to the tip of the mouth, and insert it at an either 180-degree or 90-degree angle. In general, avoid the use of nasopharyngeal airways in pediatric patients. These are the different sizes. Remember, depending on the size of the kid, you have to measure, and that way it can fit good in the oral cavity to displace the tongue. And you measure from the tip of the ear to the tip of the mouth itself, and that in that fashion right there. You can use a tongue depressor you can actually open up the airway so you can actually insert it, because the tongue is going to be in the kids is very kind of large, and it should fit that way, where it's actually pushing up the tongue out of the way, out of the airway. It says ventilations as needed. Initiate positive pressure ventilations for respiratory failure or respiratory arrest. Ventilate 20 to 25 times per minute. And attach supplemental oxygen. Use appropriate size BVM device or bag valve mask also. Remember, when you're measuring the mask itself, the pointed portion goes towards the bridge of the nose, and the flat portion goes to the chin itself, or the bottom lip. Okay. Now, there's different techniques depending, but you're always going to use your E or 3, C or 3, or C or E hold, where basically the 3 fingers that you see here are going to be basically opening up the jaw while and holding down, pushing down, while this one, the thumb itself, forming a C here, is going to be pushing pushing down, while the E is going to be pushing up. Okay, then you have the two-handed C and E also, where you have one person with both hands actually holding it, and somebody actually ventilating the patient. Okay. If the patient is breathing adequately, administer oxygen and maintain an SpO2 level greater than 94%. If the patient cannot tolerate a cannula or mask, try blow-by method. To administer oxygen, a non-rebreather mask is appropriate for a child. To administer oxygen, the blow-by method usually works better. You're not supposed to really put straight oxygen in children that are very young, less than a month old. So basically, blow-by, you're still giving them oxygen, you just not have it directly on them. Emergency medical care, position the patient, respiratory distress, if they're unresponsive, position patients in need of ventilators or ventilation, or patients requiring spine motion restriction. If they have respiratory distress complaints, also you have to transport the patient. If they have respiratory distress findings, not just complaints, but findings, and transport to children's hospital if possible. Now, luckily, we do have a couple of areas that we consider children's hospitals around this area. Foreign body airway obstruction. Suspect foreign body airway obstruction if there is a high resistance to airflow with positive pressure ventilation. So if you have your BVM and you're having a hard time trying to blow air, and there's possible airway obstruction, attempt to reposition the airway first, and if no success, assume the airway is obstructed. So the key steps are: you try to ventilate and air doesn't go in. You reposition the head, as you do the head tilt chin lift again, or modified jaw thrust, depending, and then you blow again, making sure that the airway is open. Infants and children with mild foreign body airway obstructions, if the foreign body If a foreign body and not airway infection is suspected, take actions to clear the airway. You know, it's by suctioning or doing the Heimlich's maneuver that the CPR classes actually teach you. Infants or a child with a mild foreign body airway obstruction do not intervene and allow the patient to actually continue to provide supplemental oxygen and monitor for worsening obstruction. Infants with severe foreign body airway obstructions, if the patient is still responsive, initiate steps to actually remove the obstruction. Okay, and this is when you start giving back blows and abdominal thrusts on the kid. So use finger sweeps only when the foreign body is visible. Because if you don't see it and you try to grab it or push it out of the way, you might actually push it deeper. Emergency medical care. Foreign body airway obstructions, unresponsive infants with foreign body airway obstructions. If the patient is unresponsive, initiate steps to remove the obstruction itself. Child with severe foreign body airway obstruction, if the patient is responsive, initiate steps to remove the obstruction itself. This is basically the Heimlich type of maneuver that you're doing on the kid. Unresponsive child with foreign body airway obstruction. If the patient is unresponsive, initiate steps to actually remove the obstruction. Remember, there's an obstruction, you cannot get any air in there. And in all essence, if you think about it, if you're doing the primary assessment, you cannot continue to even check for CP, I mean for pulse if you cannot clear the airway. I mean, well, you're supposed to, but ideally the way it's stated, you know, the rules that we're supposed to follow or the steps we're supposed to follow, if the airway obstruction is not relieved, there's no point in actually checking for pulse because, well, you know, the patient's going to go down and die without respirations. Chest compressions in a child who is unresponsive, for an older child, place one hand on top of the other and then start doing chest compressions. Now, some conditions that show up in kids, specifically pediatric respirations and cardiopulmonary conditions. Croup. Now, croup is an infection of the upper airway. It's common. It's common between the. Now, this is important if you want to find out what croup is and what epiglottitis is. Croup usually is common in the ages of 6 months to 4 years of age. It causes swelling beneath the glottis itself. It presents with a seal bark, and always they sound like seals. And its severe attack can actually lead to respiratory distress. So basically, at this point, the difference between epiglottitis and croup. With croup, you have, let me see if I can find my arrow. You have inflammation in this area right here. In epiglottitis, it's this that gets swollen, the epiglottis. Okay. Now, emergency medical care for croup. Administer oxygen, humidified if possible, to maintain an SpO2 level of 94% and above. Keep the patient in a comfortable position and transport without agitating the patient. Epiglottitis is considered a bacterial infection that causes swelling of the epiglottis. And in this age group, it's usually between 2 to 7 years old. Now, remember that with croup, it's 6 months to 4 years of age. With epiglottitis, it's 2 years of age to 7 years of age. So it usually attacks the older kids, well, older than croup. If untreated, it has a 50% of mortality rate, because that once that epiglottis gets stuck and doesn't let any air into the trachea, they start going into respiratory distress. Rapid onset with high temperatures. So you can have a very high temperature when it comes to that, because bacterial infections tend to be higher in temperature than viral infections. So specific signs and symptoms of epiglottitis: pain and swallowing, high fever, toxic ill appearance, drooling. Now, drooling is common with epiglottitis. Okay. Changes in voice quality, pain, speaking, chin and neck thrusts upward, and inspiratory stridor occurs. Do not place anything in the child's mouth, because if you do, then you're going to have issues with irritating the tissue. Place the patient in comfortable position, oxygen by non-rebreather masks or blow-by method. Consider ALS backup and rapidly transport the patient. Asthma. Now, asthma is considered an inflammatory process. Inflammatory process characterized by increased mucus production, swelling of the airway walls, and smooth muscles contraction. Inflammation inside the bronchioles usually causes mucus secretions and mucus plugs to actually form when it comes to asthma. So you have narrowed airways when it comes to asthma. And the issue is that it's not that they have a problem getting air in. It's usually getting the air out of the lungs that they're having problems with. So basically, when this one, what they're showing you is that the larger airways are supposed to, as the in adults and in infants, they just basically constrict. Signs and symptoms: shortness of breath, chest tightness, wheezing, non-productive cough. Questions to ask regarding medical history: how long has the child been wheezing? Have they had a recent cold or other infection? Have they had any medication for this attack? What it was, when, and how much they took? And they usually have like a little kids that have a history of asthma have like a little inhaling pump. Do they have any known allergies to drugs, foods, pollens, and other inhalants? In the assessment, pay attention to the position of the kid, the mental status, vital signs, skin color and condition, and respirations. Now, these kids, of course, with asthma are going to have diffused wheezing in all the lung fields. Maintain an oxygen to keep pulse greater than 94%. Initiate positive pressure ventilation if the patient's condition deteriorates. Assist with prescribed inhaler. If present, consider ALS backup or intercept and transport to the emergency department. Bronchiolitis is the mucosal layer of the bronchioles is inflamed by actually viral infections, often RSV. This produces wheezing and other signs of and symptoms of asthma, and there is usually a low-grade fever, often more predominant in patients less than 2 years of age. Bronchiolitis. It's not the same thing as bronchitis. So the pathophysiology, you have inflammation inside the bronchioles, and they increase in the production of thick mucus, causing the mucus to actually form plugs. Emergency medical care, maintain an oxygen level above 94%, initiate positive pressure ventilation. If the condition deteriorates,
Hey, Mom, can you come real quick?
position of comfort, monitor vital signs and mental status en route, and consider an ALS backup or intercept. Okay, so basically,
look, this is what I had the question. Because I haven't been that's how I understood to fucking do it. Okay, so the patient, vitals,
Yes.
assess.
And the ones that we've been getting is because there's no vitals. It was
okay,
just.
pathophysiology of pneumonia, mucus inside the bronchioles leads to
It's been a
reduced
good
airflow and mucus in the alveoli, causing poor gas circulation. So what happens in pneumonia, the infection itself causes
Leave it open.
the bronchioles themselves to actually suck in plasma in the that's within the blood into the lung fields, causing them to be drowning in their own fluids. Now, pneumonia infection in the lungs can actually obstruct the airways and actually lead to respiratory compromise. Signs include shortness of breath, chest tightness, diminished breath sounds, and cough. Assessment, look for position, the position of the patient, mental status, vital signs, skin color and condition, and respirations. By position, we're talking about mainly the tripod position that that patients are going to get into when they're having this type of issues. Emergency medical care, you maintain an SpO2 level above 94%. Now, initiate positive pressure ventilation if the condition deteriorates. If they tend to get worse, if you sense that they're getting worse. Place patient in a comfortable position, transport the patient, and consider an ALS backup to intercept. Congenital heart disease. Now, when we're talking about congenital heart disease in kids, it's something that they might have been born with. So it can actually be due to abnormal valves, vessels, or chambers, results in more deaths during the first year of life than any other birth defect. And the key to recognizing an abnormality may actually exist and rapidly transport the patient to the hospital. Now, these kids it's either going to be teratology of a lot, or any other one of these major diseases that their kids are born with. So they're basically the term that they use when kids are born with these type of issues, which is a transverse of the great vessels or whatsoever. It's congenital. The word congenital. That means that they were born with it. Now, sometimes they correct it right away. Sometimes they correct them while they're in the process. Now, this actually, congenital heart disease may present with inadequate cardiopulmonary blood flow with cyanosis and hypoxia, excessive pulmonary blood flow with congestive heart failure, respiratory hypoperfusion, shock, respiratory distress with or without cyanosis, or shock. Emergency medical care, maintain an oxygen to keep the pulse ox greater than 94%. Initiate a positive pressure ventilation, of course, if the patient is deteriorating. Support the cardiovascular system as necessary, and transport immediately, and consider ALS backup to intercept. Give me a few seconds, guys. Give me a few seconds. I forgot what I was doing. Okay, congenital heart disease is emergency medical care. Maintain an SpO2 level greater than 94%. Initiate positive pressure ventilation if you notice that the patient's condition is deteriorating. Transport the cardiovascular system, support the cardiovascular system as necessary. And that's when you're going to be like treating for shock, elevating the legs, keeping them warm, and transport immediately and consider the ALS backup for intercept. Shock. Basically, the causes include hypervolemic, obstructive, distributive, and cardiogenic. This common cause of shock are allergic reactions, poisonings, and cardiac or any type of cardiac events. Kids are too young to be having cardiac events. Common findings include diarrhea, dehydration, trauma, vomiting, blood loss, infection, and abnormal injuries. Signs of shock include rapid respiratory rate, decreased urination, absent tears when crying, impaired mental status or unresponsiveness, weak or absent peripheral pulses, delayed capillary refill or blanching test, pale, cool, clammy skin, and decreased urinations. Now, compensated versus and decompensated shock. For pulses, you have peripheral pulses are adequate. It's considered normal for normal patients, kids. Signs, if you might not have anything, no peripheral pulses, you might actually have signs of compensated shock whatsoever. Peripheral pulses weak or absent will be under compensated, and so forth and so forth. So, if you look at this chart, basically telling you what you're gonna find when it comes to this. Now, remember, compensated, the body will actually increase in heart rate and respiratory rate and basically maintain a blood pressure. When it comes to uncompensated or decompensated, the pulse is already going to start going down. The blood pressure is going to start going down, and respirations are going to start going down. So basically, they cannot compensate to maintain life. So shock, maintain an open airway, and use oxygen to actually maintain an SpO2 level above 94%. Positive pressure ventilation if breathing is inadequate. Control bleeding if present. Keep the patient supine and warm. Remember, you're treating them for shock. Transport rapidly and consider an ALS intercept. Emergency care protocols for pediatric shock. Establish and maintain an open airway. Extending the head only enough to allow an open airway and avoid hyperextension. Remember, with kids, you want to go ahead and see if you can put a towel on the back of the shoulders so you can actually elevate the shoulders, the chest a little bit higher, so the head can actually go into what we call a neutral position. Provide positive pressure ventilation with supplemental oxygen connected with to the ventilation device at a rate of 12 to 20 ventilations per minute if breathing is inadequate. If breathing is adequate, administer oxygen via non-rebreather mask at 15 liters per minute. Consider blow-by oxygen in infants and very young children. If shock is due to blood loss, control any external bleeding that you might actually find with direct pressure. If internal bleeding is suspected, by you actually determining it by the mechanism of injury and having a high suspicion, transport immediately and expeditiously, and also try to consider an ALS backup for intercept. Keep the patient warm. If hypothermia, is suspected, wrap the patient in warm blankets and place the ambulance heater on high, cover the infant or child's head, and actually consider calling advanced life support for backup, and then expedite transport and perform a reassessment every 5 minutes on these kids. These are not stable kids, so it has to be every 5 minutes. Okay, cardiac arrest. Almost all cardiac arrests in children result from airway obstruction or respiratory distress leading to respiratory arrest. Shock is also caused by causes of cardiac arrest. You know, there's no blood left, they're gonna go into cardiac arrest. Aggressively manage both respiratory problems and shock before they actually progress to cardiac arrest. Signs of cardiac arrest include unresponsiveness, gasping or no respiratory sounds, no audible heart sounds, chest is not moving, pallor or cyanosis or absent pulses. Use emergency medical care, positive pressure ventilation with supplemental oxygen. Utilize CPR and AED applications, early ALS backup or intercept, and do a rapid transport on these patients. The AED applied to a child. Remember, you have to use the pediatric patches on the kid. Okay, and then you could put, it'll tell you exactly where to put them. Seizures. Seizures, abnormal electrical discharge that occurs in the brain. Seizures are a brain dysfunction without muscular manifestations. Okay, causes include fever, epilepsy, or drug overdose, brain tumors, or brain injury, electrolyte abnormalities, hypoglycemia, meningitis, and hypoxia.
What? Why?
Assessment. Look for muscular rigidity or twitching, dilated pupils, irregular breathing, incontinence, and cyanosis, and excessive salivation. History findings. Check to see if they have a history of prior seizures. If so, is this a normal pattern that they normally have? Or is it the same type of seizure that they're having, or is it different? Have the child taken any prescribed medications? The duration of unconsciousness? Description of seizure activity also. Emergency medical care. Maintain an open airway and use oxygen to maintain an SpO2 greater than 94%. Provide positive pressure ventilation if breathing is inadequate. Position the patient on their side and be prepared to suction in transport. Remember that when you're suctioning a pediatric patient, 2 to 5 seconds max. Okay. Emergency care protocols for pediatric seizures. Okay, establish and maintain an open airway, extending the head only enough to allow an open airway to avoid hyperextension. It's easy to occlude the airway of the child when you try to extend the head, the neck. Protect the infant or child from injuring themselves. Place them on his left side. Suction secretions, provide positive pressure ventilation with supplemental oxygen via the reservoir at a rate of 12 to 20 ventilations per minute if breathing is inadequate. If breathing is adequate, administer O2 to maintain an SpO2 level of 94% or greater. Consider blow-by oxygen in infants and the very young children. Check the blood pressure or glucose levels, if your protocol permits it. Expedite transport if any of the following situations show up. Epileptic seizures lasting more than 5 minutes, 2 or more epileptic seizures without a period of consciousness between them, a febrile seizure lasting more than 15 minutes, seizure from any other cause like hypoxia or head injury whatsoever. Consider calling advanced life support, expedite transport, and perform reassessment every 5 minutes. Altered mental status. The change in mental status could be mild or significant. There is many underlying causes for altered mental status in the pediatric patient. The goal is to manage the life threats to the airway, breathing, oxygenation, circulation. Now remember that we basically use the AVPU to determine the level of consciousness. So we also have the Glasgow Coma Scale for children that we utilize also. Emergency medical care, maintain an open airway, use oxygen to keep the SpO2 level greater than or equal to 94%. Apply positive pressure ventilation if breathing is inadequate. Position the patient on their side. Be prepared to suction and transport and consider ALS intercept. Pediatric care protocol for pediatric drownings. Establish and maintain an open airway. Extend the head only enough to allow an open airway. Suction secretions, provide positive pressure ventilation with supplemental oxygen at 12 to 20 ventilations per minute if breathing is inadequate. If breathing is adequate, administer oxygen to maintain an SpO2 of 94% or greater. Consider blow-by oxygen and in infants and very young children, and check the blood glucose levels if your protocol permits it. Signs and symptoms of hypoglycemia are present and the child is known diabetic on medication for the condition, consider oral glucose if the child is able to swallow and medical direction approves it. Consider calling advanced life support, expedite transport, and perform a reassessment every 5 minutes. Drownings can occur in any amount of water. I've known the kids getting drowning in about a foot of water or maybe less than that. Most drownings are dry drownings that we consider dry drownings themselves. Basically, all it means is that the airway closed up and no water went in, they just closed up. Assessment considerations. Be aware of associated trauma and hypothermia, possibly a secondary drowning syndrome also, because in the secondary drowning syndrome, they might be okay and you don't take them, but let's see if they were at the beach. The beach has salt water and a little bit went into the lungs. Well, that salt water that's in the lungs starts sucking the plasma from the alveoli, and they drown in their own fluids. So that would be considered a secondary drowning syndrome. Emergency medical care, consider spinal injury, maintain an open airway, and use oxygen to keep the SpO2 level greater than 94%. Use positive pressure ventilation if the breathing is inadequate. Place the patient on their side. If possible, provide CPR and use the AED if needed. Transport with ALS backup and intercept. Okay. Protocols for pediatric drownings: remove the child from the water if diving was involved. Children. or adolescents, consider spine motion restriction. Establish and maintain an open airway extending the head only enough to allow an open airway to avoid hyperextension. Suction secretions, provide positive pressure ventilation with supplemental oxygen connected to a ventilation device at 12 to 20 ventilations per minute. If breathing is inadequate, of course. Perform chest compressions. If no pulse are present, apply the AED. Contact medical direction. Otherwise, contact medical directions for orders. If hypothermia is suspected, deliver only one defibrillation. If breathing is adequate, administer oxygen and SpO2 level to maintain it at 94% or greater. Consider blow-by oxygen in infants and the very young. If hypothermia is suspected, remove the wet clothing, wrap the patient in warm blankets, and place the ambulance heater higher so you can actually keep them warm. Consider calling advanced life support, expedite transport, and perform a reassessment every 5 minutes. Fevers, usually fevers of 104 to 105 are concerning. Basically, you're cooking brain tissue. Causes include infection, heat exposure, seizures, dehydrations may actually occur because of these. Assessment considerations. The rise in temperature more important than actual temperature itself. Change may occur to pulse amplitude. The fontanelles may actually sink down, and urinary frequency may actually be diminished. In other words, they don't urinate, so you might need to check the diapers to make sure that they are urinating when they have fevers. If they're not, that means that they're dehydrated. Emergency medical care, maintain an SpO2 level greater than or equal to 94%. Remove excess layers of clothing. Cool patient as needed in a controlled fashion, and be alert for seizures. Protocols for fever: establish and maintain an open airway, extending the head only enough to open up the airway. Avoid hyperextension. Suction secretion. Provide positive pressure ventilations with supplemental oxygen via reservoir at 12 to 20 ventilations per minute if breathing is inadequate. If breathing is adequate, administer oxygen and maintain an SpO2 level greater than 94%. Consider blow-by oxygen in infants and very young children. Okay. Febrile seizures lasting more than 15 minutes are dire emergencies and require expeditious transport and considerations for advanced life support. Consider calling advanced life support for intercept and transport, and perform a reassessment every 5 minutes. Meningitis. It's an infection in the lining of the brain and spinal cord. Fever is in infants younger than 3 months is suspected as meningitis. May actually be rapidly fatal on kids. And basically all this is that you have an infection causing an inflammation of meninges, causing for them to have a stiff neck, and fever, headache, unconsciousness. Assessment. Assessment considerations. Ask to see if the kid has had a recent ear infection or upper respiratory infection. High fever or lethargy or weakness, nausea, vomiting, fontanelle may actually bulge in infants, pain with movement, and possible skin rash. Wear masks, gloves, and possibly gown.
What?
Keep pulse ox greater than 94%. Ventilate the patient if needed and transport to the hospital. Remember, this type of disease can actually attack you too, so take personal precautions. Assessment considerations, condition conditions include gastroenteritis,
Did they get the keys?
for can actually lead to dehydration and appendicitis. Emergency medical care, maintain an SpO2 level greater than 94%. And place the patient in a position of comfort, anticipate vomiting and transport. Most common poisonings are most common in children younger than 4 years of age. A thorough secondary assessment is critically important to find the cause and gather as much information as possible about the type of overdose the patient and transport the patient. Contact medical direction. If activated charcoal, contact medical direction or poison control center. If activated charcoal is ordered, use a 1 gram per kilogram. Maintain an open airway and administer O2. If breathing is adequate, administer oxygen, maintain an SpO2 greater than 94%. Consider ALS backup. Use blow-by oxygen in infants and the very young children. Treat the specific poison. Now, if there's ingestion, if you're instructed to administer activated charcoal and the patient is alert and able to swallow, give 1 gram per kilogram of activated charcoal at 12.5 to 25 grams is contraindicated in the following conditions: altered mental status, ingestion of acids and alkalis, and patients who is unable to swallow. If it's inhaled, remove the toxic environment, maximize oxygenation by non-rebreather mask at 15 liters per minute. If breathing is adequate, or by positive pressure ventilation, if breathing is actually inadequate. Absorption, if the poison was absorbed, flush with water for about 20 minutes on the scene. If the eyes are involved, continue flushing en route to the hospital. If it's injected, carefully monitor the airway and breathing, and just in case allergic reactions can actually occur. Contact medical direction. Consider administration of epinephrine of 0.15 of the child weighs, if the child weighs less than 66 pounds. If the child weighs greater than 66 pounds, an adult dosage is 0.30, which is double the dose of 0.15. Dose should be used. Apply constricting bands proximal to the site of the bite or injection. Consider calling advanced life support, expedite transport, and perform a reassessment every 5 minutes. With the acronym BREW, basically it's a brief result, unexplained event. Essential considerations: an episode that is frightening to the observer or infants younger than 1 year of age, characterized by some combination of apnea, color change, mark change or muscle tone, choking or gagging. Even the event is usually transient. Okay, maintain an open airway and adequate breathing and oxygenation. Apply positive pressure ventilation if inadequate, breathing, and transport with ALS intercept. Sudden infant death syndrome, SIDS, which I really haven't heard too much of it, but sudden and unsuspected death of an infant in which the autopsy fails to identify why they died. Peak incidence as 2 to 4 months occurs. Exact cause is unknown. and cannot be diagnosed in the field. So basically, it's something that you're going to be doing CPR with. Assessment considerations: physical appearance of the infant, position of the infant on the crib itself, physical appearance of the crib, presence of objects on the crib. Sometimes, being from the Hispanic heritage, the baby's crib sometimes is full with teddy bears and everything, and sometimes I found out that can actually be the cause of SIDS. Unusual or dangerous items in the room also. Emergency medical care. Attempt resuscitation unless rigor mortis is already or dependent lability is present. Encourage caregivers to talk. Do not provide false reassurance. Transport with ALS backup or intercept, and use caution in communications. Aiding family members in SIDS emergencies. Reactions vary, but shock and disbelief are very common. Making decisions may actually be difficult for the parent themselves. Be supportive and aware of your own emotions. The presence of parents during pediatric resuscitation. Allow parents to be present while you're actually working on the kid, so they at least know that you're doing something. Infants who survive also have accepting of procedures when the parents are present. Pediatric trauma. Thousands of children die from unintentional injury and are more permanently disabled. Leading cause of death from ages of 1 to 14 years of age. 50% of deaths from trauma occur with the first hour after the injury itself. Many of the deaths and injuries are preventable. Mechanisms of injury that we're looking for: common modes of injury, unrestrained motor vehicle collisions, pediatrician versus vehicle, or pedestrian. I'm sorry, God, I can't even read. Pedestrian versus a vehicle, cyclist versus vehicle, water accidents, burn trauma, sports injuries, and child abuse. Give me a few seconds, guys. Thank you. Oh, gracias. Sí, aquí tengo. Gracias. Okay. Trauma and pediatric anatomy. Use assessment considerations. The head, chest, abdomen, extremities, and burns. Head injuries with children because of the relative large size of a child's head. Usually the head is a lot larger than, and heavier than the rest of the body. Be aware the child for facial injuries are especially vulnerable to airway compromise. Emergency medical care for pediatric patients: maintain an open airway and breathing, and provide high concentrations of oxygen. Provide positive pressure ventilation if breathing is inadequate. Provide spine motion restriction as needed, and transport rapidly to a trauma center. Infants and children in car seats in trauma can protect usually can actually protect a properly secured child from injury, particularly with frontal and rear end collisions. More than half of the children are improperly secured or are not secured at all. Remove the infant or child from the car seat if the seat was involved in a moderate to severe car crash, do not use it to actually transport the patient. If the crash was minor, the seat may actually be used if certain criteria are met. Removing the kid and I'm sorry, removing the infant and child from the car seat, the vehicle was able to actually be driven away from the car site. The vehicle door nearest to the safety seat was actually undamaged. There were no injuries to the occupants or no airbag was deployed. Removing the infant. Moving the infant from the car seats. The child must be removed from the car seat. It must be done in a coordinated manner. Maintain an inline stabilization of the spine itself. Safe transport of children to ground ambulances. Guidelines established by National Highway and Traffic Safety Administration. Safe transport of children. The National Highway Traffic Safety Administration in 2012 recommendations for safe transport are divided into 5 different situations. Ideal recommendations are provided if they are not achievable after practical recommendations. Okay. Excuse me. Safe transport of children in ground ambulances, uninjured or not ill child at the scene, or injured or ill patients injured or ill child does not require extensive monitoring, and child who requires continuous and intensive medical care or monitoring or interventions. Safe transport of children in ground ambulances. Child who is in condition requires spinal immobilization or lying flat, or child requiring transport and part of a multiple patient transport. Infants in child car seats, we have 4-point spine motion restriction of an infant or child. All times the EMT must be able to actually improvise the restraint of a child with equipment intended for an adult. So we have our spider straps and whatsoever. So secure the 3 body straps across patient in the chest, waist, and above the knees themselves. Place the straps across the
Children.
and chin securely after and affix the patient's head to the pediatric sleeve. Excuse me. And then we have a picture here of a kid actually secured to the backboard itself. Injury prevention. Preventable childhood injuries account for 44% of deaths between the ages of 1 to 19 years of age. Injury is prevention must be of paramount concern to actually EMS providers. Child abuse and neglect. Physical abuse takes place when improper or excessive action is taken on in the injuries or causes them harm. We have sexual abuse indicated by the involvement of a child in sexual activities
956
the gratification
821
more powerful
2338.
Neglect is the provisions of inadequate attention or respect to someone who has a claim over that attention. Emotional abuse takes place when one person shames, ridicules, embarrasses, and or insults other to damage the child's victim's self-esteem. Two adults, the adult who actually abuses a child often behaves in an invasive manner and may show outright hostility towards the child themselves. An abuser or an abused child usually shows fear and reluctance when asked to describe how the injury occurred. General indications of neglect and child abuse: multiple abrasions, lacerations, incisions, bruises, or broken bones, multiple injuries or bruises in various stages of injury. Give me a few seconds, guys.
Hi.
Hi.
Afternoon.
Give me a few seconds, guys.
How are you?
I'm doing okay.
My name is Jadelle. I'll be your nurse for tonight, alright?
Okay.
If you need anything, just give me a call.
Okay. General indications of child abuse and neglect: multiple abrasions, again, lacerations, incision, bruises, or broken bones, multiple injuries at various stages of healing, injuries of multiple planes of the body, unusual wounds, and pattern injuries, and a fearful child. Injuries to non-bumper areas such as the genitals, abdomen, and what's areas that you normally don't bang when you're walking or whatever. Injuries to the brain, spinal cord, and that occurs when the infant is vigorously shaken, which is called shaken baby syndrome. Injuries that do not match the mechanism of injury is described: a lack of adult supervision or untreated chronic illness. Malnourishment or unsafe living environment, delay in reporting injuries, impossible explanations caused by the child's developmental age. You know, he fell down the stairs when he can't even walk. Come on. Basically, this is radiator science of the heater radiator that houses in the north use, and this is kind of injuries from a switch or on the tire, or actually school-age children. The loop marks from being whipped with an electric cord. Okay. Emergency medical guidelines for child abuse: you have to involve the law enforcement if the scene is dangerous or you cannot gain access. Do not ask the child what happened while they are in the crisis environment. Perform a head-to-toe exam and make observations as if the scene was a crime scene. Okay, take the child to the hospital. Do not question the caregivers about abuse or make accusations. Do not allow the child to be alone with a suspected abuser. And EMT must actually are mandatory reporters. So you have to report it either to the police department or the ER doctor. Emergency care guidelines for the child abuse: document objectively and record vitals or details, and keep information confidential. Special care considerations: emergency medical services for children is designed to actually ensure that the children have access to appropriate emergency care. Established in 1984, it has provided grant funds to all states. family centered care, advocates often communication in the family with family members throughout the assessment and management of the child. EMS providers must be able to actually anticipate physiological and emotional needs of the child themselves. Taking care of yourself, caring for infants and children can actually be very stressful because of the lack of experience in treating them. So fear of failure or identifying patients with your own children themselves. Reduce the stress, realize that much of what you know about adults applies to children with variations in the techniques that you do. Okay, practice your skills, especially when we're dealing with a patient assessment of a child. Focus on the tasks at hand themselves. Okay, basically, we're done with this chapter. So I know this is a very long chapter. I'll see if I can set it up to record if you missed any part of it. You have any questions? I'm gonna go ahead and call it a night, guys. I'll post. I have the other previous two videos set up already. So I'll set them up hopefully as soon as I have a chance to I've uploaded two of them already. I haven't uploaded this one, and I'll send you the link to them through your email. Okay, so we'll call it a night. Any other questions? Feel free to ask.
Hey, sir, my mom wanted to know if you can call her real quick about somebody that was trying to get certified.
Let me see. Yeah, let me give me about 5 minutes and I'll call her.
Okay, thank you.
Okay, thanks.